Dear colleagues, I'm Nana Yazarian. I'm the director of the Armenian Eye Care Project. I would like to warmly welcome you all, and I would like to present you the AECP Charitable Foundation, Sergei Milan Ophthalmological Center, and Department of Ophthalmology of Yerman State Medical University. This is the AECP Grand Rounds, which has been organized by all these facilities. This is a series of specialized discussions. This is the second or the third discussion already. We're very happy to present you the Grand Rounds because they have an aim of following very serious results. And today the topic will be pediatric ophthalmology, and I would like to present our guest today who will be leading our discussion today, and then she will present also our residents who will be talking today. Dr. Ruzana Harutyunyan, who's a PhD candidate of medical sciences, she's the associate professor of the Department of Eye Diseases, Yerevan State Medical University after Mukhtar Heresy. She's the head of the Department of Pediatric Ophthalmology, Sergei Milan Ophthalmological Center, and she's a fellow of the Armenian Eye Care Project. And she is the lead of the pediatric programs. And from the US, Professor Stefan Purpose is joining us, who's from the UCI, University of California, Irvine, and he is an ophthalmologist there. He is the American Ophthalmology Academy member, and he is a member of Armenian Association of Ophthalmology. And before passing the speech to you, I would like to tell you that our physician will present you the pre-test with which we will start our discussion today, and after that we will continue with our discussions. Please, it's a pleasure to have you here with your residents. Thank you very much for presenting me. And first of all, I'd like to greet you all, my dear colleague. I'd like to greet you all, Dr. Stefan. And this is a morning for you, but it's an evening for us. We'll be very happy to listen to you regarding our topics. First of all, I would like to say that the two topics that we chose today, I think that it will be very interesting to all ophthalmologists, and it's concerning ophthalmology, the foundations of ophthalmology, and this concerns the terms that every ophthalmologist work with. So first of all is the pediatric ophthalmology, and of course, why not also adult physicians may work with this. And that's why we will talk about the main functions, which are called, first of all, binocular vision, and then second of all, we'll talk about amblyopia. And these are those basic, foundational, important knowledge pieces that we need to update day to day. And this is important for all ophthalmologists. And that's why today we think that it was very important to invite my young colleagues to present you the topics regarding this. And before proceeding, I would like to ask you to respond to a few questions, and these are referred to all the participants. We really need your responses on these questions, and in the end, we will finalize our topics, and we'll also do a post test. The test will be provided before the topic and after, and this is an accredited meeting, by the way. We want to really update your knowledge, fill the gaps that you might have due to some reasons, or maybe because you forgot something or you didn't have time to update the knowledge. First of all, the very first question which will be asked is, where does the fusion occur? And the second question would be, at what age does myelination optic nerve fibers end? Third question, specify the type of strabismus, the angle of deviation, whether it's variable, depends on the position of the gaze, diplopia is characteristic, and secondary angle is larger. This is one section which will be presented by the first resident, and the second section. Why does the brain ignore or suppress signals coming from the amblyopic eye during the competitive process? Next question, what changes occur in the brain during amblyopia? Please refer to these questions, try to respond, and we'll be happy to answer these questions at the end of this talk. Dr. Stefan, I would like to present you my young colleagues. The first topic would be regarding a very important term that we have in ophthalmology, and that's amblyopia. Please. Hi, everybody. I am Lina Gishian. I'm a resident in Sergei Malyan Ophthalmology Center, and I will talk about amblyopia, current treatment options in pediatric population. Amblyopia is a diminished vision, and this happens during the visual development because of abnormal visual stimulation or abnormal binocular interaction. It's usually monolateral, but it can also be bilateral. And the causes of amblyopia are usually refractions, strabismus caused, and deprivation. The refraction issues are hypermetropia, astigmatism, myopia, as well as refraction error differences between two eyes, which will be more than one diopter. I would like to mention that in hypermetropic children, amblyopia is observed more frequently. The next cause is strabismus. In pediatric age, brain is suppressing the amblyopic eye to avoid diplopia, and that's why in this eye vision development is halted, and deprivation. All the pathologies that partially or completely lead to irreversible changes of the vision, for example, pathologies in the eyelid, which may lead to paretic lid, changes in the lens, central issues in the retinal area, as well as optic nerve changes. Classification of amblyopia based on the severity level, we have the mild one when the visual acuity is up to 20/40, the moderate where the vision is 20/40 to 20/80, severe where the vision is 20/100 to 20/400, and the very severe one when the vision is less than 20/400. The main methods for diagnosing amblyopia are the medical history, visual acuity testing, refraction, external examination, checking visual alignment and mobility, stereopsis testing, apparent pupillary defect, checking whether it's there or whether it's absent, anterior segment examination, and fundoscopy. Let's talk about the changes that occur in the brain during amblyopia. A competitive process, aspects of neural selectivity, structural and functional changes, as well as changes in ocular dominance columns. The competitive process. During the visual development, the monocular errors lead to retinal competitive process, and when impulses coming from one eye become weaker and the cells are not able to compete with the other cells, and that's why the brain is suppressing the stuff that's coming from that eye. How does brain choose which eye is the stronger one? It's based on synaptoplasticity, activity, and neuronal network learning. Synaptic plasticity. Based on neuronal activity, synapses may change and they may adapt, and that's why in amblyopic eye, synapses are absent or they weaken, and in the other eye, the synapses become stronger. And next one is activity dependence. Due to active process in the neurons, and the connections become stronger in the brain, and that's why due to the weak stimuli in the amblyoptic eye, the connections are not becoming stronger in the brain. And next aspect is neuronal network learning. We know that the brain is processing all the information, creating and reinforcing new connections, and in case of amblyopia, this process is affected. Changes in the function and structure, this also happens in the primary visual cortex, and in the lateral genicular body, there's atrophy, loss of cross-linking between connections, and loss of lateralization. The atrophy happening in the cells, especially in the layers which receive information from the eye. The loss of cross-linking, we know that the connections are not just simply processed from the primary visual center, but also there are some cross-linked areas, and in case of amblyopia, these connections are becoming weaker, and that's why the processing of the information, the completeness is affected. And the loss of lateralization. We know that what does it mean? The cells in the brain are losing the ability to process information, and we receive it from two different eyes, and that's why the stereopsis is disrupted, and interaction between eyes is kind of disrupted. A very interesting study has been performed in children with amblyopia using OCT and MRI, and they discovered that there had been changes in the gray and white matter, and there have been variations in ciliary muscle thickness, changes in choroidal thickness, differences in retinal nerve fiber, changes in the thickness of macula, and other structural changes. As already mentioned, the columns of dominance are changing, and the dominance columns are placed in the visual cortex, and those are neuronal cells which are directed linearly, and they understand whether they should respond to the right or left eye stimuli. And there was a very interesting study in the primates. Immediately after the birth, one of the eyes has been sewn, and in a month we've seen that the sizes in the columns have been changed, and in the other eye they have been enlarged. And with time, in the critical stages, when the eye was open and the healthy eye was closed, it was observed that the dominance columns have been normalized. And whenever the critical area has been missed, we didn't see any changes returning to the normal state. As we have already known, the critical stage is very important for the treatment, and that stage is up to 7 or 8 years old. For treatment, we have very important 3 steps. First of all, is treating the cause behind amblyopia. The second one is correcting the significant refractive disorder, and third one is to promote the amblyopic eye. As we already know, the first approach is the optical approach and optical correction, and with this method, in some cases, I would like to mention that this method can be completely sufficient, and especially in anisometropia. The disadvantage is cooperation with children, and it doesn't happen in all cases. For example, in deprivation cases. The next one is the occlusion therapy or closure therapy, when we close the healthy eye and we're trying to stimulate the amblyopic eye, working the gold standard for this. This is a gold standard method, and both these therapies have show really good results. This is another example of a cooperation issue. Also, hypopigmentation, irritation of the eye. These are also kind of the other sides of the positive effects. If we have defects in the other eye, we need to stop the treatment. And there has been performed a study with this intervention in mild and moderate cases. We know that we can close the eye just for 2 hours, but in severe cases we need 6 hours. So if we close for longer hours in the mild moderate cases, we'll see the same results. Next one is the drops. The first choice is, of course, atropine. It's not worse than the closure method, but just closure method is faster overall in terms of the results. But after the long-term evaluations, we can see that the results are the same. Side effects are the disadvantages, and photosensitivity, dryness in the mouth, tachycardia, and of course, in this case, we have reversible amblyopia risk. And one of the disadvantages is that in case of myopia, it's not efficient. It's more efficient in hypermetropic children. And studies has shown that it's enough to do this not every day, but with some periods. The effect would be the same. During the past years, we have been talking about binocular therapy, and we have FDA-approved two games. These are Curified and Luminopia, and this method is very interesting, and I think it's very stimulating for children, and it has a very high efficiency. One of the disadvantages is that it's not available in all countries, and in not every case you can use this. Luminopia 1 is a digital therapy when the child is at home and they carry the VR glasses, and there's a video which has a certain type of contrast. It has a specific contrast for the healthy eye. It has been approved for children from 4 to 12 years of age, and the treatment is 90 minutes per day and 5 days per week. The next one is CureSight. This is also a digital therapy. You can perform it at home. You need blue and red filtered glasses and a special device. And this device is following real-time changes in the eye movement, and it kind of decides which one is the amblyopic eye, which was the healthy one, and based on the contrast, it provides a treatment. The treatment is the same as for the previous one. Overall, by choosing the correct treatment and on the right time, we can provide children with the best vision and visual acuity. Thank you very much for your attention. Thank you. Of course, this was a very interesting topic, and this topic has more space to do studies. I would like to share with our colleague, Dr. Stepan, I would like to share our experience, and I would like to hear your experience. Of course, we're talking about the central nervous system, the changes there. We talk about the competitiveness, we talk about neuronal nets. We're studying that in dark matter, gray matter, and white matter. Or we're talking about the retinal areas, and we have all this information and the interpretation of all of this. We're talking about just one term that we're talking about amblyopia in the end, and all ophthalmologists know that this is a diagnosis, that we have it, and we don't want to see these changes developing in a deeper manner, and we don't want to have irreversible changes, because we know that in the literature, we have reports that if the brain is working with a stronger eye, it will not try to promote the lazy eye, and we may have irreversible changes. So it may start from the first days of the birth, and we start the work just from those periods, and we want to fight against amblyopia becoming more severe. And it depends on it depends whether this is an obscuration amblyopia, whether this is strabismus or refraction amblyopia. We have just one aim: to help the child to restore it before the CNS learns to work with just one eye. So, Dr. Stefan, it will be really nice to hear your advice. It will be nice to hear your knowledge. What would you say in terms of this topic, please?
Well, first of all, I thought that presentation was wonderful. I almost wish we could show it to our residents here. It was complete, clear, and that was just very well done. I enjoyed it. The only slight thing I would add is the amblyopia from deprivation is really a different problem than the amblyopia from strabismus or refraction. As you said, if you correct amblyopia by age 7 or 8, which is your limit of your window for strabismic or refractive amblyopia, you have a good result. But deprivation amblyopia is a much more urgent problem. And if the deprivation is complete, such as the picture of the child with the monocular cataract, I believe, you have to catch that immediately. If you have a monocular cataract that goes undetected, by 3 months of age, that eye will develop some sensory nystagmus, which is a sign to me that the amblyopia is irreversible. So the amblyopia from total deprivation must be corrected urgently, as opposed to the strabismic or refractive amblyopia, which has a much longer window of opportunity. So it's really a different thing. Rather than amblyopia from suppression, it's actually amblyopia from like you say, deprivation. That'd be really the only thing I would add to your very excellent talk.
Yes, I would like to agree with you completely. And for us, pediatric surgeons, we already understand that from the time of since the child was born, whenever we see the cataract or whenever we see changes in the optical environment that will lead to a deprivation amblyopia, we need to respond really emergently so we will not have deprivation amblyopia. I totally agree with you. Because already in a year or two, whenever we see a very severe nystagmus, this just says that amblyopia is irreversible, and there's a very high chance that we will not be able to reverse the vision in this child's eye, despite that you performed the surgery in a very well, even though you put the lens perfectly, but the brain is asleep, sort of, and um, it will not get the information from that eye. Thank you very much. Do you have any other suggestions? Do you have any other advice, or we should proceed with the next topic?
Just to take a little moment up because I'm interested in it, the binocular treatments of amblyopia, the luminopia, there are put forward by the companies that make the devices, so there may be a bit of a conflict of interest in their motivation, but it's really based on a different theory than occlusion or patching. Patching is really a monocular treatment of amblyopia. The concept of the binocular treatment, it recognizes that amblyopia was a suppression of binocularity, so it uses your remaining binocular vision to reverse the amblyopia. So besides having much better compliance with the children, it really works on a different theory at attacking the cause of the amblyopia rather than just the monocular treatment. And because of this, there have been some reports of the strabismic amblyopia being reversed even at older ages. Now, personally, I have my doubts about that and I haven't seen it, but that is being discussed too. If indeed this binocular treatment is effective, it may widen the window.
Yes, thank you. And if you agree, let's proceed with the next topic, which will be presented by our next colleague. And this will be about binocular single vision. We'll talk about neurophysiology, about whatever happens in the CNS. Shall we proceed?
Yes, I look forward to listening to it.
Hi, I'm Marina Chobanyan, and I will talk about binocular vision and why is it important in pediatric ophthalmology. As already know, binocular vision is based on the fusion, and we're talking about sensory fusion and motor fusion. In sensory fusion, we mean that we have the combination of both images coming from both eyes when the images are coming from the corresponding dots from the both eyes, and they have the similar sizes and shapes from both eyes. And the motor fusion is based on the movements that help us to have the sensory fusion, and the images will be in the fusion area. The image created on the retina and it passes on the lateral geniculate body, and then it reaches the visual cortex, and then it reaches to the higher regions. In the lateral geniculate body, it's a very important node, and it has a dorsal area that receives image signals and the ventral area which receive non-image forming signals. In the retina, we divide two types of pathways, and these are passed through the geniculate body, and they preserve their separate paths. The next area where we get the information is the visual cortex, and it consists of 6 layers. Let's talk about all of the layers. The first one is the molecular layer, where we don't see the bodies of the neurons, where we only see the axons and dendrites. And the main function is to mobilize and to strengthen or weaken the signals. And the second layer is where we see a small stellate or pyramidal neurons, and these provide the connection between two hemispheres. And the third layer is very important. And here we see the large pyramidal cells, and here we see the fusion. And because we have the binocular cells here that receive the vision at the same time from both eyes. Fourth layer is the main layer, because here we have the visual information coming from the lateral geniculate body, and here we also see some sublayers, and each one of these receive the information from the retina from an appropriate region of the retina. The fifth layer, here we see the large pyramidal layers, neurons, and the signals are passed to the superior colliculus, and this part participates in the visual reflexes and managing them. The sixth layer is more modulatory and a grouping function. And the last node is the superior colliculus, and it's a midbrain structure, and the main function of the structure is to coordinate eye movements and provide the reflex movements of the eyes. And especially here, we have the on and off signals coming from the retina, because every cell here has receives information from 5 or 6 cells coming from the retina. And the complete retina is mapped on the superficial layer of the superior colliculus. The main 5 functions of the center are the control of visual reflexes, regulation of saccadic eye movements, direction of visual attention, and of course, because besides this visual center, we also have the centers for other sensory centers. We have sensory integration happening. Here I tried to explain that during the development, what are the changes happening in the nervous system. The glutamatergic and GABAergic signals in the proteins, there are structural changes happening which lead to reduced plasticity and higher kineticity. This happens in 5 stages. During the first stage, this is a very early stage when we see the development of visual acuity and the binocular vision development happens. The early childhood is from 1 to 4 years of age. Here we see the perception of motion and contrast. In this stage, the biggest danger here is for the development of amblyopia, but for the treatment, these are really efficient. Next one is the school age, from 5 to 11 years of age. Here we see the plasticity when it reaches its higher, the peak, and then we see the stabilization of synapses. The first stage is happening during the from adolescence to adulthood, and this happens. The molestation continues up to 30 years of age, and we see the changes of the mediators from excitatory to inhibitory. And the fifth stage is after 55 years of age. It's when we see decline in visual acuity, plasticity, and visual function overall, based, and of course based on the comorbidities and their development. Here I will talk about the strabismus and classification. We talk about paralytic and non-paralytic. In the paralytic, we're talking about when we have paralysis of oculomotor muscles in one of several, and the angle depends on how far the eye is deviated, and in the non-paralytic one, the angle is very constant. And in this case, we do not see binocularity because we don't see suppression in this case. The third type is the one that we see from, these are the inborn issues, when we see abnormal development or incomplete development of the muscles and their innervation is incomplete. And then the next one is the central strabismus, when we see disorder based on CNS disorders, and these are accompanied by other CNS diseases. Now let's try to understand that after the surgery, how how can we evaluate whether we'll be able to restore the binocular vision? There are several parameters that affect this, and let's talk about them. First of all, this is the pre-surgical sensory fusion, and we perform different tests and we try to understand whether the patient has sensory fusion or not. So if there's a sensory fusion, then we will see restoration of binocular vision. It's very important that we will evaluate the visual acuity in both eyes, and it shouldn't be less than 0.5. So in this case, we will be able to operate on the fusion process. It's very important to know when is the onset or the duration of strabismus, what was the environment, what was the mechanism. It's also very important was the age at onset for the patient. The higher the plasticity, the better the opportunities to restore vision. And of course, it's very important what would be the remaining angle after the surgery. It should be very small. It should be less than 8 prisms, so we'll be able to provide the fusion. We have several cases in which there is a high risk for postoperative period. First of all, these are the adults that have strabismus since their childhood. The second one is the macular disease. And that's interesting that also people with TBI who have strabismus and besides from the regular strabismus, they also have a rotatory component. And this is called horror fusion kind of diplopia. And even after prismatic intervention, we will not see reduction of strabismus, and we'll need to properly evaluate this. I included the studies here that you should perform before the surgery. These are, of course, we know this. These are the cover and cover tests, prism cover test, fusion adaptation and amplitude evaluation tests, which give an opportunity to test what's the kind of the strabismus, but also the sensory function. And Worth test helps us to understand what's the sensory fusion and whether a person has abnormal correspondence in the retina. Baccolini test is implemented in the patients who have correspondence issues. Anomalous retinal correspondence is the test. This is the state when there is a fake macula and when the new locus starts to work well without the eye center, and after the restoration of the eye, we see some difficulties. Next one is mapping the suppression areas, because we want to understand which areas are suppressed the most and what are the sizes of the areas, because if they're central and if they occupy large areas, in this case, the binocular vision restoration will be quite difficult. And the last one is the first action test. And we perform this to evaluate the mobility of the eye. This is a little study that there have been 20 patients involved in this study. Patients had exotropia, more than 35 prism, and the patients were older than 20 years of age. The first group of the patients were, those were 11 patients. In the pre-surgical stage, the fusion was proper and the binocular vision was restored completely. In the second group, there have been 5 patients that had suppression, fusion suppression. The function was reduced, and in 80% of patients we saw restoration. And the third group was the paradoxical diplopia, where these patients were able to restore the function only in 50% of patients. So overall, to conclude, I would like to mention that understanding the mechanisms behind the binocular vision is very important to properly manage patients with strabismus. And in the pre-surgical stages, it's very important to perform fusion potential tests to understand what will be the risk for postoperative diplopia, and this will help us to accurately plan the post-surgical period. Thank you very much. Thank you. I would like to highlight that every ophthalmologist, whenever they see a patient, especially in the younger patients, it's very important to fight for the patient's high vision. We want to have high vision in both eyes, depending on whether it's a lens, whether it's with glasses. And the next stage is to reach in a stage to a stage in a patient when the patient would have binocular vision and when the patient will have stereo vision. If the visual acuity is just one complete in every eye, it doesn't mean that the patient is completely healthy. If the patient doesn't have binocular vision, then it's not complete. Of course, the function will not be complete in this case. The patient may have 40% esotropy, or the patient might have anti-prismatic diopter esotropy or exotropia. But in each of the eyes, the patient will have one complete 100% vision. But this will not mean that, in terms of ophthalmological health, the patient's sanity is complete. And based on these studies and these examinations, we have an opportunity to understand and to diagnose a nosology that we call diplopia. Whether it's visual, whether it's ocular, what's the cause, when did it develop, what's the mechanism for the diplopia? We need to understand this, because if we don't know the mechanism of diplopia, and if we didn't know if the patient had this kind of issue before, it will be very hard to understand what will be the further causes of the visual loss. That's why I think that it's very important to update the knowledge for our colleagues, for ophthalmologists. I think it's important to talk about this, because studying binocular vision, this helps us to talk about different kinds of nosologies, diseases, and thus we can understand what would be the disruptions of binocular vision, and we'll be able to trace diplopia. Dr. Stefan, would like to hear your thoughts on this, please.
Okay, again, as with the first talk, just an excellent presentation. I enjoyed relearning some of the things I had forgotten about neuroanatomy. The only thing I would stress again from a clinical point of view is the discussions of suppression and ARC really affect how you handle the surgeries, and also it's age dependent. For instance, with esotropia, the suppression scotoma is usually central, and when you do your surgery, you want the post-op result to be as straight or as orthophoric as possible right away. When dealing with intermittent exotropia, that's really a different problem than esotropia. Usually it starts intermittent, so you get less amblyopia, and the suppression is more of a hemiretinal suppression, so that when the eye drifts, the child usually does not complain of diplopia, because that hemiretina is suppressed. When you do your surgery on a younger child, or just let's just say adolescent, you aim for your surgery to almost overcorrect, to have him look a little esotropic, to put him in his non-suppressed retina. So post-operatively, he may have some diplopia, but the plasticity is so good that the diplopia usually ends within a couple weeks, and it knocks out the original suppression of the hemiretina, and then you might have a good alignment that stays. If you use the same approach with an adult, I notice your table had the adults with the exotropia. I'll just assume some of them started as intermittent and became constant. Their suppression is much more permanent. So if you overcorrect an adult to put him in his active retina, he will have diplopia, but the plasticity is gone, so the diplopia may persist and persist. So when aiming for an adult with exotropia, usually you don't try to overcorrect. Indeed, you might leave them a little undercorrected, even though cosmetically it may not be ideal, but you'll have much less problems with diplopia, while in the younger patient, you aim for the overcorrection to get better fusion and binocularity. Just be wary of postoperative diplopia in overcorrected exotropes.
In high exotropy, in high angular cases, we suggest our patients to have a few stages surgeries. We have the first stage when we perform an incomplete correction, when we do hypocorrection, and then we do the next step in 6 months or so. We perform the second stage, where we try to avoid the irreversible diplopia. In adults, this works, but not in children, and we try to avoid irreversible diplopia. And we don't want to do overcorrection. We don't want to change the direction of the angle, and we don't want to have a reversible diplopia. And in these cases, we do surgical intervention with few stages. First, for example, if we perform recessions of the external rectus muscle, and then we perform resection of the internal rectus muscles, we do it in one eye and then in the next one, depending on the angle and depending on what would be our expectations in this patient, depending on the visual acuity and age. Of course, in children, because of the plasticity, they kind of help us. They kind of help us to have a little higher efficiency. Of course, I'm a little joking here, but their plasticity, the connections are stronger, and they're able to fix those smaller corrections that we might see in pediatric cases. But in adults, we're, we're very cautious. Do you agree with these statements?
Yes, completely.
Very well, thank you. There's a question here. Dr. Manemosinian is asking a question. What would you do in a child that is 13 years of age? What would you do if the patient has cataract that is inborn, and we can do either the cataract could be either total or diffuse. So if the patient is 13 years of age and did not undergo any surgeries, the causes may be different. So the lens is affected in a kind that in 13 years of age, this may lead to irreversible changes of the vision. Of course, we would not want to see worsening of the case like that. But if there is just one central tiny cataract and it does not affect any visual functions, if the visual acuity is 1, and if the child doesn't feel that there is this local darkening, I think we will just keep on the follow-up. But if there is an issue, if there's a danger that the visual acuity might go lower, and regardless of the age, we have to operate, and we need to give an opportunity to the child to restore their vision based on the possibilities, of course, based on the causes of the lens darkening. Thank you.
If it's a small cataract and that I didn't feel it was significant, certainly would leave it alone, but I would follow. And if it's worsened, I would deal with it if it affected the vision. If it was a total cataract and we didn't see the child until they were 13, and it was already nystagmus in the eye, and it was one eye, I wouldn't do any surgery. If it was a 13-year-old patient that had total cataracts in both eyes, I might do the surgery, just feel that whatever improvement in vision would be a benefit. But I certainly wouldn't operate on a monocular total cataract that in a 13-year-old that had been present since soon after birth.
To be honest, I would honestly, if there was a monocular cataract, I would definitely suggest surgery just to have the cosmetic improvement to reduce the phenomenon of whitening, because this might lead to elevated eye pressure, and this might also lead to intraocular changes in the future. I would have suggested a surgical intervention. So we will give an opportunity at least for the sunlight to reach the child's eye fundus and to stimulate whatever it is, whatever visual function we have there, even if it's monocular. Of course, if we are able to operate on that. But again, if it's just a point cataract, if the child doesn't feel it, and if it doesn't affect any of the life activity, if it doesn't affect any of the daily activities, of course we can keep it under follow-up. Thank you. Here, I want to ask you, Dr. Steven, what would you say if a child has amblyopia and if it's impossible? So if we have a case when a parent is not able to ask the child to close their eye, we don't have cooperation, what would you do? We have a monocular amblyopia, the visual acuity is 10%, and the child doesn't close their eye.
A very real problem in pediatrics. If it was strabismic or refractive amblyopia, where I really thought prolonged effort would help as opposed to deprivation amblyopia, I would probably use penalization with the atropine, knowing it doesn't work well. But if I really had no success with compliance or cooperation with the patch, and the choice was just giving up or trying the atropine, I would try the atropine. But that is a very real problem, and I have no good solution for it other than to try to educate the parents as much as possible. But sometimes even the best intentions can't be realized because the child may have what we call ADHD or hyperactivity problems that just preclude the possibility of them being compliant with the glasses and patching. So you just do the best you can. But yeah, I would do atropinization, regardless of whether it was myopic or whatever the cause was.
And what would you say about penalization? Do you think that it's a practical alternative approach? What's based on your experience?
Yes, in my opinion, it's not as effective. I usually don't use it as a primary method. I basically use it again when patching fails. So I haven't found it to be successful. There's difference of opinion. Some of my colleagues are more positive about it, but I usually only use it as a last resort.
Yeah, I agree. Because first of all, accommodation opportunities in children are so big that the higher diopters, what kind of glasses would you need to use to penalize the eye so the weak eye would work? It's not really applicable. And throughout the years, I didn't try to penalize and to treat amblyopia this way. The other question, Dr. Steven, what would you say when we say that during the myopia, besides glasses, we also try to implement atropine drops, 0.01%, just to reduce the stress due to accommodation. Besides glasses, besides all the devices that we give, besides all the classical recommendations, what's your opinion on long-term implementation of atropine drops?
That's a topic I'm personally very interested in, and I feel most of my colleagues are in support of it. So my personal opinion, I believe, is a minority opinion. My feeling is, even at the low dose, my reaction is, are we absolutely sure that years of 0.01% atropine may not in some way cause some problems when the child is 30 or 40, some unknown cause? And the answer I receive when I ask the question is, at this low dose, we don't believe so. So personally, I'm not satisfied with that answer. So I actually don't recommend atropinization, even at the low dose, even though the results from the Singapore studies are somewhat positive, and many of my colleagues do recommend it. I don't. I recommend that the vulnerable kids, ones with family history, just spend as much outdoor time. And if they're in contacts, to use peripheral defocus contacts. If they can get access to peripheral defocus lenses, I would use that. I'm not sure they work, but they do no harm. And I personally recommend against atropine as I do against what we call orthokeratology, the corneal reshaping treatment, which is also popular among some of my colleagues. So my feeling is no atropine.
Yes, I agree with you. I personally, my colleagues and I, we don't really accept the long-term atropine implementation because in the end, atropine is atropine, regardless whether the dosage is high or low, and it may have its side effects. And the last question, Doctor, all our colleagues that are here with us listening to our topics and context, I would like I want them to hear about your experience regarding overnight lenses. What do you think about their usage?
Again, what we call orthokeratology or corneal reshaping. You're talking about for the treatment of myopia, correct?
Yes, just for treatment myopic refraction.
Again, as I suggested, I'm a bit negative to it. I don't do it. So the only children I've seen that have had it are ones that have developed a corneal ulcer or other scarring. So my personal feeling is it is not safe, not only from a theoretical point of view, like the atropine, from a practical point of view. And if indeed the cornea is scarred or otherwise warped in some way, and it's not successful, I think when that child grows up, if he chooses to have LASIK or surgery, I think the LASIK will be unpredictable in an eye that's had orthokeratology. So I would, again, recommend to my patients, don't do it. And if you become myopic and you're an adult and want to do something, then do one of the refractive surgeries that we have a better understanding. But with children, don't do anything to harm their eye that'll affect them when they're adults. When they're an adult, let them make their own decision about myopia.
Thank you. And overall, in the pediatric ophthalmological practice, do pediatric ophthalmologists, do they like to use it, or it's not that widely used?
Among here, the pediatric ophthalmologists pretty much do not do the corneal reshaping. They do the atropine. The corneal reshaping is done by our colleagues in the field of optometry. So we have some professional disagreements with our optometrists, where most pediatric ophthalmologists do not do corneal reshaping.
Dr. Stephen, we're very grateful that you joined us and that you dedicated your time to join us. And would like to invite you in the fall to our international congress that we have here, Ophthalmology Congress here in Yerevan. Would you be happy to join us?
Thank you very much. Let me talk to my colleagues and also the wonderful group that has coordinated with you. The group, I guess, that was founded by Dr. Raja Honesian and now John Hovhanesian, no relation, coordinate. So over the years, I've talked to them about some of the work they've done and I've done. And I'm a bit older now, so I don't travel quite as easy. But thank you very much. And I will discuss it with John.
Now, dear colleagues, I'd like to reread our questions, and I will be wait for your question responses. And of course, it will be interesting to see the progress before the topic and after the topic. What will be the differences between the answers you provide? Where does fusion occur? And the second, at what age does myelination of the optic nerve fibers end? And the third question, specify the type of strabismus. The angle of deviation is variable, depends on the position of the gaze. Diplopia is characteristic, the secondary angle is larger. The next question. What changes happen in the brain during amblyopia? This was regarding amblyopia, right? You've been very active to respond to the question, of course. We'll combine all the answers. Thank you very much for this evening. I would like to thank all the participants. I think that you tried to refresh something in your knowledge and your experience. Thank you.